us up, awakened us up, sensitized us, concerned us, all kinds of reactions, which are all appropriate. Tonight, we're going to try to begin to address them. We're not going to, in 1 hour or so, we're not going to be able to adequately address any of these issues, but we're going to begin a dialogue. It's really important that we talk about these things and that we have an open communication about these issues and not sweep any of these things under the rug, whatever they are. First of all, I want to thank Rabbi Foxbrunner and Rabbi Tendler for arranging this. I want to thank Dr. Blumenthal for being available to us. It's really kind of him to make himself and his time available to our community at a time of need. Thank you very much. And I know this is what you do often. Thank you for being there for us. God's seal is truth. And the only way that we're going to be able to see any healing in issues like this is if we're truthful, if we're open and we're straight about things. It doesn't mean non-discreet, but it means that we're straight and open and appropriate in dealing with these issues. So first of all, for those of you who are not clear or people who are, there might be some mystery, let's just be clear about what happened last week. A young man who many of us know, who has worked here in the community, grown up in the community, who was part of the community in many, many ways, had some kind of a personal crisis. That's for others to define. And that crisis led him into shul where he threatened to kill himself. And he had discussions, pretty extensive discussions with his family, with loved ones, and with the police negotiating team, and with me as a rabbi. And after all of those discussions, he actually carried out his plan and he shot himself and he died. That's what happened. It's tragic, obviously, it's terribly painful. Our first concern, obviously, was the pain that he was in and now the pain that the family is in, understandably so. And that's what we all want to be. We all want to be there for the family in any way possible. And we know that there's almost nothing we can do to alleviate their pain. But that's what we're dealing with. Now, obviously, every one of us thinks about things and has different reactions, and this raises all kinds of issues for us. So first of all, I just want to mention it's Hanukkah. And Hanukkah has a very interesting law. If a person has to make a choice between Hanukkah candles and Shabbos candles, the person is so impoverished that he can only afford one and not the other. The halacha is clear that Shabbos candles come out first. Why? Because Shalom Bayis wins. Now, Shalom Bayis is commonly understood to be a relationship between husband and wife, but it really means the bayis, the household, the community, the shul. Shalom Bayis means the well-being of our extended family. And there's been a little bit of a break in the Shalom Bayis, there's no question about it. When somebody takes their own life, when somebody's in such pain, when we start realizing that there are people like that in such pain that we don't know about, there's a kind of a Shalom Bayis that's not there. It's not Shalem, it's not whole, it's not complete. And let's also be honest with ourselves about something. Obviously, we're concerned and we have tremendous compassion for the victim and for his family. At the same time, we're also victims. There's no question about it. We are victims because our sacred space, which is always a place of serenity and peace and sanctuary, was violated. And it raises questions, if not in our own minds, raises questions in our children's minds. On a personal note, I will tell you that we just had the privilege of being present at the naming of a grandson who was named Moshe Tuvia, Moshe after Moshe Twersky, who was murdered in a shul on November 18th, 2014, together with 5 other people. 4 people who were davening there and a 5th Druze policeman. 6 died months later after a long coma. That was an unbelievable violation of sacred space, a different kind, absolutely. But sacred space was violated now as well. And so in a certain sense, we're all shaken up, not only by the pain that we feel for somebody else, but we're also concerned, what does it mean about our community? What does it mean about our holy space? What can we count on? What can we rely on? So the other thing about this, about the event that occurred in our shul is that it occurred in our shul. meaning somebody was in great distress. Where did he go? He went to a shul. He went to a place of holiness. He went to a place that was known as God's home. He went to a place where he could actually see Tashmishe Kedusha, touch Tashmishe Kedusha, and utter prayer to Hashem, as we know he did. And so we want our shul always to be a place where people in distress can go. Shuls sometimes appear to be places for the well-to-do, for the people who've got everything working, everything going well for them. Or even if it's not going well, people come to shul and act like everything's going well. And we want our shul to be a place where it's okay for things not to be going well, and you're still welcome. That's really what a shul should be. A shul should be a place of safety for people in need. So it's really important for us to recognize that. It's Hanukkah, and it's a Yom Tov of Hodah, of thank you. It's a Yom Tov in which we practice the art of appreciating. We appreciate the role of Hashem in our lives, the role of the miraculous, both the open miracles as well as the miracles that are not so open. That's what we're doing on Hanukkah. We should pause and appreciate the fact that we have a community that has each other's back. We love each other. We don't always show it, but we do. And the moment we have an opportunity to show it, when we know that somebody's in need, thank God, people come forward in droves with all kinds of creative and straightforward ways of helping others. And that's something we should not take for granted. And we actually want to train ourselves to appreciate. Appreciation doesn't happen just by acknowledging, yeah, that's true, it's a good thing. Appreciation is a way of being. It's a whole attitude to life. And if we focus on things that we can appreciate, one of them being community, we can actually gain tremendous strength just from knowing that we are part of a community that has as one of its major themes, caring for each other. And so that's a major asset as we go through any kind of a crisis, and certainly this one. Let's talk about suicide for a minute. We know that suicide is prohibited. We also know that the Shulchan Aruch says that somebody who takes his own life isn't even buried together with everybody else. And that halacha is practically, it's an academic halacha. Nobody who's contemplating suicide is opening a Shulchan Aruch to find out if it's okay or not. And even if he found out it's not okay, his view of his life and his view of the lack of hope and his view of his future or his relationship with other people or with God is so skewed that he doesn't believe that that applies to him. And he knows that that's the only option. Or even if he doesn't know it, he thinks that maybe that is the only option. And so we have tremendous compassion in halacha. Halacha has tremendous compassion for somebody who thought that this is what had to be done or thought that this is the only way out of a problem or a dilemma. And that's why we relate to this person as a victim. He's really a victim of his own thinking, and he's not a perpetrator as much as he is a recipient of, he's an honest. He really had a person like this feel that he had no choice. He had no real bechira. Now, let's be clear. The life that we have is not our own. And that doesn't mean it's always a gift. Some people have a life that's not a gift. It's also not their own. There's a God in the world. And we have to live our lives as if the life that we have comes from God. Whatever life we have comes from God. If a person is confronted with bad news about an illness, and for example, he decides that he doesn't want his family to have to suffer through his illness, or he doesn't want to have to suffer through his illness, and he takes his own life, that's a thoughtful decision that is condemned. That's absolutely inappropriate. So we all want to be clear about that. But the kind of suicide that we deal with as a mental health issue, that's not condemned. It's not, and obviously it's not an option we want anybody to consider, but it's not halachically condemned, and it's not judged. The person is an honest, the way somebody who gets sick didn't choose their illness. What do we want to do about all this? Just some thoughts to begin the conversation, and I'm sure many of you have thought about these things. You know, sometimes we're around people who are cheerful or personable or giving or caring or functioning well, and we just don't know what they're really dealing with. We just want to be aware. We really don't know what others are dealing with. And that means that we want to have an extra ear, and we want to ask when we say, hi, how you doing? We really want to mean the question. And even if we can't take time at that moment. We want to say to somebody, maybe we should talk. Can I call you later on? Would you like to come over? Or whatever it is. We need to make ourselves a little bit more sensitive to the very, very feeble signs that sometimes people broadcast that say, things aren't so well with me right now. That doesn't mean they're a suicide risk. It means that they're having a hard time, and we want them to know that we're around. We want to support others. Imagine if every day we woke up and we said, I'm going to find somebody today that I can provide support for. It would change our orientation to the day. Most of the time when I wake up, I'm worried about getting through the day, but it's important to actually change our disposition. I'm going to find somebody that I can make a difference for today, that I can show support for. It's very important for us to do that. About mental illness, we really have to open up a conversation about mental illness. And we have to realize that mental illness is not a failure. A person who has a mental illness didn't choose it. Not only that, they so badly don't want to be that way, and they can't help it. It's not something they did to themselves. It's something that happened to them, the way, God forbid, cancer happens to a person, the way a flu happens to a person, the way COVID happens to a person. It's not something a person chooses to have. And not only that, the people around someone who's mentally ill aren't failures because that person is mentally ill. Somebody who suffers chronic depression, it's not the family's fault that that person's suffering chronic depression, even though sometimes it occurs to the sufferer as if it's somebody else's fault. That's part of the mental illness. But so one of the reasons we avoid it is because sometimes we feel like it reflects our failure, that somebody else that we love and care for is not doing well mentally. It's not our failure. It's the way it is. And not only that, mental illness needs professional attention. We can't solve it. We might be able to make it worse, but we can't solve it just by being nice or just by hoping to distract the person or that kind of thing. It needs professional attention. And there's nothing wrong with seeking out professional attention. We need to destigmatize the whole arena of mental illness. And let's be open about something else. There are children in our community who are suffering mental illness. And it's so much more difficult for their parents to deal with it straightforwardly and seek the help that their children need when we're not open about the fact that this kind of a thing happens often enough. It's real. There are children who need attention, and sometimes parents are hesitant to get that attention because of the stigma that we put on young people having mental illness. But it's a very common issue, and it's something that we don't want to run away from. There are different kinds of mental illness. Substance abuse can be seen as a mental illness. It's not a moral failure. Substance abuse, drinking, we need to be aware of that, and we should not be making light of alcohol as a problem. It is a serious problem among young people and in our society. And sometimes drinking in our community is done under the guise of some kind of religious celebration, highly inappropriate. And we are also leading people who have a major problem into a bigger problem. So we have to be very, very straight about our discussion about alcohol, drugs, and that kind of a thing. Got to be straight about it. There are many people who are vulnerable to having their lives destroyed because of what goes on at Kiddush sometimes. So let's be straight about it. It's a problem. Sexual abuse exists everywhere, not meaning in every community. There's no community that's immune from sexual abuse. And as a rabbi, and I'm sure my wife would say this also, in my routine interaction with people, I find that there are people who are either recovering or not recovering from sexual abuse, sometimes as it's going on in their lives right now. These are real issues, as well as a general issue of mental illness, bipolar illness, chronic depression, that kind of a thing. These are real things that our community suffers from. Torah doesn't immunize anybody from any of these things. The fact that somebody is religious doesn't in any way mean that he's less susceptible to any of the problems that I just mentioned. Before COVID hit, I shared with the shul a picture of my vision for the shul over the next few years. One of the things that I described in great detail was a Jewish-centered counseling center. Shuls, communities need to provide not just Jewish counseling, meaning counselors in a Jewish building, but Jewish value-centered counseling. People need to be able to look at their shuls as sources of mental health, as resources for those kinds of things. And we need to open up this discussion and see what can happen in our community. So those are just some thoughts I'm throwing out there. I'm really eager to hear from Dr. Blumenthal. Miriam, is there anything you wanted to add to this?
Yeah, I'd just like to add to the people in the Atlanta community that this has been a big blow to us, but we want to recognize the fact that Yosef Pepper came to Shul. Shul is us. He came to us. He came to our arms. And we are a community that is centered around the Torah and around the Kodesh Baruch Hu as the pivotal piece of our lives. That gave him comfort. When he died, so to speak, he died in our arms, and he came to our arms to support him. So even though we're looking at what can we improve, what can we do better, how can we be more loving to each other and support each other and accept all different kinds of troubles that people go through, that in the past we would say, oh, that's their fault or they caused it. And we're beginning to see that that's not the case. I think we have to realize that we've started from a very powerful place. We have an unusually loving and close community, and we should feel good about that and build on that and feel that we actually offered Yosef comfort in his last moments because he came to us, he came to HaKadosh Baruch Hu in the context that we all created at the shul.
Very important point.
And Hashem should heal all of us together, and we should help to heal each other.
Amen.
Amen. Okay, thank you, Rabbi and Rebbe Feldman, for your words. I'd like to ask Dr. Blumenthal to unmute, and I'm going to share the spotlight. Just 1 second. I'm going to unmute you.
Okay. All right. Thank you. Hi, can you hear me now?
I want to start by thanking you profusely for being so available to our community. As soon as I emailed you, you responded right away and have been consistently responding and helping to guide us with some of the resources we've provided. And I thank you very much in advance for your time and your words of guidance. Thank you.
Okay, thank you very much. And Rosh Rabbi Feldman and Rabbi Foxbrenner, I'm reminded of when I grew up in the shul. I grew up in the rabbi sometimes used to begin his sermon, before I speak, I want to say something. So I too would like to say something before I speak. First of all, on behalf of OHEL, under whose auspices I am doing this, and our CEO, David Mendel, and our Presidium of Mel Zachter and Jay Kestenbaum, we want to extend our condolences to the Pepper family and to the community at large for your recent loss. I want to thank Rabbi Feldman for his introduction. He actually reminded me of a very famous story they tell about Rabbi Lookstein, who is one of the great speakers from here in New York. And he once went to an out-of-town community where there was a young rabbi, and he gave one of his spellbinding oratorical masterpieces. And afterwards, the young rabbi came to him and said, "Rabbi, that was a beautiful speech. I wish I had given it." And Rabbi Lookstein said to him, "You will." I think what you're going to find is that a lot of what I'm going to be saying, Rabbi Feldman already said. Maybe I'll say it in more clinical terms, but your Rav really captured really the relevant topics, and much of what I'm going to say is just going to be that reinforcement. And also want to personally thank Rabbi Foxbrenner for all the efforts he made to put this together and for his leadership. Well, I hope this will be a discussion. I have boundless time. So I've already lit my Hanukkah candles and Daven Maariv. So as long as we need to meet, we can meet. I'm going to speak maybe for a half hour or so, but I do want to give people a time to ask questions, make comments. I think probably we have a fairly large crowd. What would make the most sense is to enter your questions on the chat. I will suggest to you that they're having done many webinars these last few months. There are probably 3 ways that you can either put in a question or a comment on the chat. One would be to just for everybody to see who it comes from, if you want that. so you can do it to everybody. If you would rather not, it would not be known who's asking the question, you can direct it directly to me or to Rabbi Foxbrunner, and we'll address the question anonymously or comment or the input anonymously. If you want to, if you have something you want to discuss that you don't want it to be known that it's you, and you don't want it publicly brought up, you can do so, address it to me or to Rabbi Foxbrunner or to Rabbi Feldman, and make note of that in the chat, that this is something private. And certainly if it comes to me, I will make my effort to get in touch with you and discuss it privately. I also want to tell you that I met with the rabbis, I want to thank Deborah Sheffer-Seaman for organizing that through Prisma. I met with them on Thursday night, with your rabbis, with your mental health professionals, with your school personnel, and I can tell you you're in very good hands. It was a very high level discussion, a lot of sensitivity. I gained from it. I even got some pointers that I think will be useful. So I just want you to understand that you have very good leadership here, very professional. And so I'm happy to be of assistance as we go along, but you have your local homegrown products are quite advanced as well. What I'd like to do during this half hour is, first of all, try to explain suicide and what prompts, what we understand, what we know, what we don't know about what would prompt someone to take such a radical action. I want to talk about whether suicide is or is not contagious, because I think that's important, especially with regard to maybe our children and ourselves. And then, of course, what the community can and should do. So first of all, suicide is very counterintuitive. Most of us instinctively want to live, and many of us will go to great lengths to ensure that we live. We practice safety, we put on seatbelts, we practice social distancing when it's necessary. Hopefully we avoid products and foods that are bad for us. But even if our life is threatened, well, even the animals will go to great lengths to preserve life. I'm personally a child of a Holocaust survivor, and my childhood abounded with stories of heroic acts to preserve life. So it's very confusing that someone would appear, and I'm saying very specifically, appear to choose to take their life. It really doesn't make sense. It sort of seems to go contrary to our nature, and hopefully I'll be able to explain it in a fashion that will understand it a little bit better. So I want to say, as I said, I want to explain to you what causes suicide, and I want to dispel the myth that it is alone simply just an incredible amount of pain. That's part of it, but it's much more complex than that. There are many people who are in terrible pain who are not at all suicidal, and there are some people who are in a lot of pain and are suicidal. As I mentioned, my mother survived 7 concentration camps, lost her entire family. It scarred her for a lifetime. My early memories are of her nightmares, but she was never suicidal, and she suffered terribly. Why would she not be suicidal? Why would never someone like Yosef be suicidal? So what I want to do, what I'm propose to you is that, like all mental illness, suicide is an illness and has the contributing factors are in many respects strongly resemble those that contribute to even what we consider a more medical or more physical illness. So let me give you as an example. Let's take heart disease as an example. So if somebody, God forbid, had a heart attack, let's even say had a fatal heart attack, we could say that there were 3 factors that brought this person to that place where a person died of a heart attack. One is a family history, a genetic predisposition, and certainly cardiologists will tell you, many have said to me that that's the most important factor, that a family history of heart disease predisposes somebody to heart disease. Then there are also environmental factors. So if the person is eating a high cholesterol foods and a little bit too much kishka on Shabbos, and has a sedentary lifestyle, is sitting around not exercising, is smoking a pack of cigarettes a day, these are environmental factors that will again make it more likely that that person will have a heart attack. And then there's a presence of a disease, whether it's clogged arteries, arrhythmia, hypertension. There's an illness that these factors come together, again, genetic predisposition, environmental factors, and the presence of an illness, and can result in a fatality. Well, mental illness, and in this case, suicide, is identical. There is a genetic predisposition to suicide. it runs in families. Perhaps most famously is the Hemingway family. As many of you know, many members of that very famous family, and we probably know it only because they are so famous, but did take their lives. And very often when I'm dealing with suicidal patients, if I take a family history, there's a grandparent, there's an aunt, there's a cousin, there's other members of the family who are struggling with suicidal ideation and actions as well. We don't know yet what is the suicide gene, or some suspect it's a crisscrossing of certain genetic predispositions, possibly depression and impulsivity. We don't know yet. It's only a matter of time. And probably in most of our lifetime, they will discover which gene or cluster of genes are responsible for this predisposition. In fact, interestingly enough, I could see that some people are thinking and saying, well, for example, I'll just give an example. We know that identical twins raised apart will have a higher correlation of suicidality, even though they're raised in different environments. So you might say maybe what's transmitted is the mental illness, not necessarily the tendency towards suicide. But studies have shown that if there's a parent with one type of mental illness and suicidality, and the child has a different mental illness, there's still a greater likelihood that that child will be suicidal. So there's pretty clear evidence that there is specific genetic predispositions to suicide. So we have that piece, which is, again, the genetic predisposition. Then we also have the environmental factors. There are certain events that can occur in a person's life. The person is in a great deal of pain over those events. It could be a loss. Those are very commonly causes. It could be a financial setback. Many of the clinics that we have today, certainly in the New York area and probably by you as well, which were, even the Jewish ones, like Jewish Family Services, started during the Great Depression, when there was a high rate of suicide because people were unable to make a living. Disfigurement, chronic pain and illness, these are environmental factors, and that may exacerbate. Some of you may be aware of some of the news that's coming from Japan, where there's been a high rate of suicide, and many attribute it to some of the great pressure that's put on employees in Japanese firms and companies. So there is that environmental piece as well. And then there's the presence of an illness. 90 to 95% of people who die of a suicide have a mental illness, most commonly depression, although most depressed people are not suicidal. That's an important point. But most commonly depression could be borderline personality disorder, could be schizophrenia, it could be anxiety. In fact, borderline personality disorders also have fairly high rates of suicide. So we have in essence, these same three factors that seem to come together: genetic predisposition, environmental factors, and the presence of an illness. And this is the key point, which again, Robbie Feldman said so beautifully, it's no different than any other illness. And that's what we have to keep in mind, not only in terms of destigmatizing mental illness and destigmatizing situations, but also how we interact with family members who have lost a loved one to suicide. They could have just as lost a child to cancer. It's no different. It is an illness caused by these classic three features. In fact, I'm going to share with you a quote from a Reverend Ron Rolheiser. I don't know who he is, but the quote says it very well, so I'm going to quote him. He said, "A person dying of suicide dies as does the victim of physical illness or accident, against his or her will. People die from physical heart attacks, strokes, cancer, AIDS, and accidents. Death by suicide is the same, except we are dealing with an emotional heart attack, an emotional stroke, emotional AIDS, emotional cancer, and an emotional fatality." And so therefore, as I said, when we come to comfort the family, we have to treat them no differently. I will tell you that many years ago, when I had been running, at that time I'd been running a twice yearly retreat for parents who lost children. And most of the losses were from cancer, from aneurysms, car accidents, falls, any number of factors. And when the first time someone applied to come to the weekend and lost a child to suicide, there was some mixed feelings on the part of my staff. Some people felt that all these other children struggled so hard to live, and this person chose to take his life. Maybe it shouldn't be in the same weekend. And my counter argument, and I guess I was the head of the department, so I prevailed, was if you know anybody who's suicidal, they're struggling with their suicidal ideation. They have an internal battle. They want to live and they want to die at the same time. And it's no different. And we included these parents and subsequently other parents, and they fit in perfectly because it really is comparable. So that's the piece in terms of trying at least to understand what prompts somebody to take life. And if you know someone who is suicidal, it's almost like they're driven. It's like they have to fight an impulse. And there's something about how their brain works that takes them there. The other point I want to talk about, which I'm sure is of concern, is there a contagion? If there is a suicide in one's community or a suicide that's known, will there be a rise in suicides afterwards? This has been seen to be the fact. It's known clinically as the Werter Effect, W-E-R-T-H-E-R, based on a novel that was written in the 19th century by Goethe about a young man. It was The Sorrows of Young Werther. It was a young man who fell in love with a woman betrothed to another man. He wanted her to break the engagement. She refused. He took his life. And after the publication of this very popular book, there were a rash of suicides in Europe. There was comparably in America in the 50s, a rash of suicides after Marilyn Monroe took her life. And we've seen this. So since then, there has been sort of an kind of understanding between the media and between the media and I guess the community, that if a celebrity dies of a suicide, the means of death is not emphasized. It's emphasized that the person died. Now, first of all, before I even get into what happened to media since then, the contagion does not mean that someone who's not at all suicidal will suddenly become suicidal because they hear about one. And by the way, there are two types of situations that would cause this contagion. One is proximity, in other words, what happened to your community, if the suicide occurred within your community, or if it's a celebrity, and because the celebrity's suicide is highly publicized. It will not create suicidality in someone who's not suicidal. But as I mentioned earlier, people have suicidal tendencies. There are people who have suicidal tendencies who successfully triumph over them. But there are people who are struggling with suicidal tendencies. Knowing that a celebrity had taken his life, or knowing that it had happened in the immediate community, could tip the scale. And we've seen that happen. So it's a concern for those who we know are suicidal. It's not a concern for someone who does not have those tendencies at all. Now, I said until 2014, and what happened in 2014, some of you may have figured out already, but Robin Williams took his life, and there was a shift in the media, and his suicide was highly publicized. I would even say to some extent, even idealized. Some of you may have seen that was distributed by Disney was a picture of the genie hugging Aladdin and says, "Genie, you are free." Alluding to Robin Williams. Since then as well, there was that Netflix show 13 Reasons Why, which was a show about a young girl who took her life because she had been so mistreated. And it was originally a book, and then it was made a very popular Netflix film. And many people said, this is great. Now we're going to talk about it. It's going to come out in the open. But now we know several years later, and we can look back, that after both Robin Williams' self-inflicted death and this film, there was a rise of suicides in this country. So there is a contagion. Now, the truth is, and I think the way we can look at it is not because I think people have become callous and uncaring, but we so live in a world today where everything is out there. There's no privacy. We don't withhold information. We live in the age of the internet and social media, so there's no withholding. So therefore, we have to be more concerned about those who have those tendencies. If there was a suicide in one's proximity area. And by the way, children and teens in particular, and particularly young teens, seem to be most prone, based on studies, to this kind of copycat suicide, if you will. Now, one very important point, which is important to clinicians, but it's important to spouses, children, and parents as well, which is asking someone if they're suicidal does not increase the likelihood that they will act on those impulses. They'll either look at you and say, no, what are you talking about? No, not at all. Or they'll tell you. And asking and they're telling you, as I said, you don't have to be afraid to bring it up if you suspect something, because they're telling you, if anything, it's a relief. In my experience, when I ask somebody, they tell me they feel relieved because it's finally out there and they can talk to somebody about it. So we have to be concerned. And anyone who is, dealing with depression or other mental illnesses, and especially if they have suicidal ideation or a history of suicide attempts, or if there's a family history, of suicide, these people, after an event occurs in such close proximity, they have to be asked. And if you're not comfortable yourself, then have a professional do it. But this is, again, there's no harm in doing that. Let me bring up some other very quick points because I want to overstay my welcome. First of all, there is another condition which we have an abbreviation for. We call it NSSIB, because everything today is abbreviations, but it stands for non-suicidal self-injurious behavior. It's colloquially known as cutting. That there are people who, again, as a result of their particular mental illness, have a compulsion to inflict pain upon themselves. Most famously is actually cutting themselves, but it takes on other forms as well. It could be banging one's head, ingesting things that cause pain, punching oneself. It takes on many forms. Was for many years believed to be most common among teenage girls. We're now becoming aware that it's common as well among adults, and it's common among boys as well, except boys don't come for help as frequently. Now, this is not with suicidal intent. In other words, the person who is hurting himself or cutting himself does not want to die. There's just two problems. First of all, sometimes they can miscalculate, and sometimes the cut can be too deep and it can result in a fatality. Also, there's some more recent research that suggests that if they have engaged in this behavior in a while, it can develop into a suicidal impulse. It's not doesn't take much more to harm themselves, and therefore this is a population to be concerned about also in terms of suicidality. You might have also noticed that I have refrained from saying commit suicide. And again, as Rabbi Feldman described, the word commit harks back to a time when it was considered like a crime. You commit a crime. And therefore, even though it's so commonly used that way, the suicide survivor community has requested that we try to change our lexicon, try to change how we express it. And so therefore we talk about dying of a suicide, taking one's life. We try out of sensitivity to the family, we try to get away from using the word commit. And again, as the rabbi explained, the halachic prohibition is not talking about people, mental illness. It's really probably referring much, I've heard this from many rabbis, not that I'm a rabbi, but it's referring more to people who very deliberately decide in a moment of sanity that they don't want to live any longer, much like Socrates who drank the hemlock. That's a whole different, but certainly halachically, that's not doesn't have bearing today. Just to mention also some of the things that were brought up by Rabbi and Rebbitzin Feldman. The Rebbitzin said very beautifully that we're a community and we help each other. Research shows fairly convincingly that community connection is an antidote to suicide. That feeling like you belong and people care can help those who are struggling with suicidality. Very interesting was a study that came out of Israel, I think about 2 years ago, where they compared the Haredi community, the so-called ultra-Orthodox, I hate that term, ultra-Orthodox, I feel like it's a brand of gasoline, but the very right-wing religious community with the general population, and found that even though the rates of depression are comparable in the two communities, the rates of suicide are lower in the religious community. And there's comparable studies that have come out from Christian communities as well, that people who attend church services regularly are there's lower rates of suicide. So again, the community, as the Rebbitzin said so beautifully, is very important. The rabbi referenced alcoholism and substance abuse. The presence of substances and alcohol increases the likelihood of somebody acting on a suicidal impulse. And of course, it makes sense because these substances and suicide reduce your inhibitions. So that mixture isn't good. And last but not least, as the Rav said again, we have, and then this is what I'm going to conclude with, how important it is. I know I'm preaching to the choir, but how important it is that we destigmatize mental illness, that we destigmatize psychotherapy. It's interesting, again, some of the studies show that people who do end up taking their lives are not, well, there are lower rates of their attending therapy. In other words, they tend not to be in treatment at time. They have a history of being in treatment, but they tend not to be in treatment at time. And interestingly enough, are going shortly before they took their lives, had made a lot of visits to physicians for medical care. So it seems that they were trying to address their anguish and pain through, in a somatic way, through symptoms, which again speaks to how important it is to sensitize our physicians to mental health issues. And I know that we're doing at OHEL something called integrated care, which is more and more popular, which is bringing mental health professionals into the physician's office. We have been doing it in the geriatric population. We're bringing mental social workers into the gerontologist's office to have mental health personnel available at that point. In terms of what the Rebbitzin said, that he came to our shul, he sort of died in our arms, beautifully said. I'm very touched by that. And I want to give you also some information that might reinforce it. First of all, it is interesting locations that people decide to pick, and they very often are places that are, with which they have positive associations, believe it or not. Many suicides take place in the parents' bedroom. They go back to places that are associated with love and care. And interestingly enough, 1 out of 3 suicide victims leave notes. The majority of those notes are loving notes, they're not angry. Sometimes they are. In fact, as the Rav alluded to, abuse victims, the abuse victims' notes tend to be angry, but for the most part, they're loving and very often apologizing to the family members and urging them not to grieve too much. So it seems that when the person succumbs to those impulses, it's not done out of hatred and anger, it's done out of warmth and connection. And it's hardly a condemnation of your community or your synagogue that this was the venue in which he picked it. But again, I want to just emphasize psychotherapy works, medication works. We have accomplished a tremendous amount. Psychiatry and psychology is one of the newest fields in medicine. And what we have accomplished, I mean, Freud wrote his first book in the late 19th century. What we have accomplished over these 100-some years is little less than remarkable. So there's treatments out there, and there's nothing we have to be ashamed of. If we're not ashamed of cancer, if we're not ashamed of heart disease, we don't have to be ashamed of mental illness, and people should feel free to just seek out the help. I sometimes say, we have a tradition to say a Misha Berach for someone who's sick. And so if somebody comes up and submits a name, you right away ask, what can we say? The person had a mental illness. In fact, I want to conclude with something that I witnessed not so long ago that changed me, that really pierced me and changed me. I teach a course. One of my other hat I wear besides running OL's trauma team is that I teach, together with David Pelkowitz, we teach prospective rabbis at Yeshiva University. We teach them counseling skills, we teach about mental illness, etc. A program that has been mushrooming actually, and our rabbis are very well trained in these skills. And I teach a course in bereavement. And the way I teach the course is I do 1 week lecture, and then the other week I bring in someone who suffered a loss, someone who may have had an early parental loss, someone early widowhood, someone who lost a child. And the last class I bring in, I'm not going to mention, although they're very public about it, I'm not sure if I should have asked them before I mentioned this, but to you, but I bring in a couple who lost a son to suicide. And the father said something a few years back, as I said, changed me. He said, if my son had cancer, I could have spoken about it, which meant I could have talked to people. I could have found out, do I have the right oncologist? Do I have the best person? I could have asked people to daven for him. But because my son had a suicidal depression, I couldn't be public about it. So I don't know if I had the best psychiatrist or the best therapist. And I had nobody davening for him. And that's what happens when there's stigma. And we have to reach the point that if somebody has a child or a loved one or any loved one who is suffering from mental illness, they can be as open about it as any other. We can all daven for the person. He can do a Misha Berach for that person. And then, God willing, tragedies that have beset your community and beset all communities will be a thing of the past. Okay, so let me open it up. Actually, I didn't have a chance to check the chat while I was speaking, so let me look at the chat for a moment. And oh boy, okay.
Dr. Blumenthal, let me
sure.
Let me start with some of the questions. We had an email
okay,
earlier
sure.
that we asked for questions. There are a couple of people who pre-submitted their questions, so we'll start with those, and we'll try to get to as many as we can, both in the chat, the general chat, and the direct messages to myself. So one of the first question, which is repeated in different words, a very important question. One of the first people who wrote in on the form, they said, I'll just take a few of their poetic words. They said, sometimes it is those you never see cry, never see be mean, consistently trying to help or please, the quiet peacemakers who remain surface level in emotional involvement with others who are at risk. This is someone who put some effort into this question.
So in other words, how do you know? Is that,
so yeah, that's a question that has come up a lot. How can you help? How can you identify people who are in despair? And is there something we can do about it?
Okay, excellent question. Maybe I unconsciously try to avoid that because it's not one that's going to make us mental health professionals look very good. But the overwhelming research on a mental health professional's capacity to predict who will die of a suicide. In fact, I often, when I speak about this, I'll be a little parochial. I quote the great New York philosopher Yogi Berra, who used to say predicting is very difficult, especially about the future. Our capacity to predict who will and will not die of a suicide is no better than a layperson or anyone else. The problem isn't so much that we know the risk factors, as I alluded to many of them in this speech. So you're going to be wondering, well, if you alluded to them, why don't we know? The problem is what we often refer to in the field in mental health as the false positives. So perhaps the easy example is what I mentioned about depression. The vast majority of people who die of suicide are suffering from depression. The vast majority of people who are suffering from depression are not suicidal. So I could say, well, depression is a risk factor for suicide, and certainly by now it's routine that when you screen a patient, you ask them about suicide. But even let's say you're not a mental health professional doing a screening, but if somebody tells you they're depressed, it doesn't make sense to ask, are they suicidal? Yes, I think it does make sense. But the vast majority are not suicidal. So we can say depression is a risk factor, but we can't use it as a form of prediction. So, but we have to still do screen, and we still try to predict and anticipate because we have to, because it's life and death. So we need to do that. But the person is right that some people do not divulge, and maybe as we destigmatize mental illness, people can be more open about it, and we will save lives. The other thing that might be alluded to in that question, which also makes this so terribly difficult, is not uncommonly when right before someone does take their life, they're very calm. There's a certain serenity because after years and years of an internal battle and struggle, they've kind of made up their mind. And so we've had situations where people were in a very agitated state and had felt that strong impulse to take their life, and everybody's watching them and keeping an eye on them, and then they'll say, I'm okay, I'm all right, I'm fine, and they may leave to get some help, or they might feel like, okay, we can wipe our brow and not feel alarmed, and that's when they actually take their life. So your question is well taken, and if you know someone who had, if there's a loved one or a friend who had taken their lives, and you're searching, and of course for the family, it's a torturous experience. Should I have known? Why didn't I know? We don't. We can't. We have a hard time protecting. There is one message though that I think is important for those of you who have children, particularly teenage children, which is that there's a very strong sort of understanding between teens, very healthy understanding, that teens don't, quote unquote, rat on each other. They don't tell on each other, which is good because teens shouldn't be spying on each other and telling adults. So if they're engaged in some harmless but wrong behavior, if they're texting on Shabbos, if they're cheating on a test, or they're talking to girls and they're in a setting where that's not acceptable, I don't think teens should tell on each other. But if it's a life-threatening situation, our teens have to know, even if the person made them swear upside down, backwards and forwards not to tell anybody, they have to. And that goes for suicide, that goes for driving while intoxicated, that goes for eating disorders. That it can also be very dangerous. In those instances, they have to break their vow and tell an adult, because you don't want to be that teen, and I've dealt with them. You don't want to be that teen who the victim told and made him swear not to tell anyone else, and they have to live with that. So that's a message that has to be part of our education, our chinuch, with kids as well. It was a long answer. I hope I addressed it. If not, I'll talk about it some more.
A related, yes, thank you very much. A related question, somebody chatted here. Would a person know if they personally were suicidal or predisposed to it? Right?
So,
The first
okay,
question was about
those are two
perceiving
different
others.
questions, right?
Right.
No, nobody is suicidal and is not aware that they're suicidal unless they're very psychotic. I mean, if they're very much out of touch with reality, or you know, in that kind of extreme range, then that maybe could be, but that's very, very rare. Now, predisposed, they may not be. A situation I'm in, and my work is mostly what we call postvention, because I go visit families right after a loved one died of a suicide. And sometimes I, you know, again, I give them the speech and I tell them there's a genetic predisposition. It's not because you were so mean to the person, not because you were lacking. They had this genetic predisposition. And it's very difficult. I'm sweating bullets. It's a very hard visit. And it's finally over. I'm ready to go home. And just then, sometimes, usually it'll be an oldest teenage girl will turn to me and say, let's say the father died of a mother died of a suicide. And she'll say to me, does that mean I'm predisposed? Does that mean my children will be? And my answer to her is, yeah, maybe. And you have to be extra specially careful about your mental health. And you have to be extra specially careful about the mental health of your children. Just like if cancer ran into you, if you were BRCA1 and cancer ran in your family, or if you had or heart disease runs in the family, you have to be very careful. If you're a BRCA1, if you have that gene, you have to take mammograms early. You have to be more careful in terms of examinations, etc. It's no different with this. If you have that tendency runs in the family, if you're careful, you attend to your mental health, you go for help when you need it, you take medication when you need it, you can have a full, rich, normal life like everybody else does. So you know, so there is, so sometimes it happens that a person doesn't know. It could come up later in life. It could be, you know, let's say if it's a woman, I could say it could be part of, if there's a postpartum depression, which is fairly common, that could morph into suicidality because there is that tendency in the family. So there could be not an awareness that they have a predisposition. That could be. But if they are actively suicide, it's very rare that they wouldn't know that.
Thank you very much. Another direct follow-up. Somebody asked, just getting very specific, we'll zoom out in a minute. A few people asked similar questions about if you're worried about somebody who has, the way they phrase it is suicidal ideation. At what point would you call 911 or seek help strenuously? What are the signs to look for?
So again, this is, you're hitting me in my soft spot because we're not good at that. But the signs you would look for, and again, they're far from perfect because our ability to predict is limited. But you would look, obviously, for severe depression, obviously for previous attempts, obviously family history, sometimes trying to settle your accounts, calling people you haven't spoken to a while just to connect with them, trying to pay back debts, or make up with people with which there are feuds, if there is that tendency that might be indicative of a decision to take one's life. There, again, a loss. There's sometimes what we call reunion fantasies. There's a wish to join the person, and that can prompt more suicidal. There's also something that we refer to sometimes as passive suicide, which is not a person who would be deliberately take their lives, but is reckless with their safety in terms of how they drive, in terms of taking, not taking precautions when they're doing repairs, let's say on the roof of a house or something like that, almost as if there's a wish to die, but or neglecting their health, ignoring potentially dangerous symptoms, high blood pressure, not taking their medication or something like that. And that could also be a risk factor. If you're not sure, again, sometimes I say to people when they call me, what if there's a 5% chance? Still, it's life and death. Let's not take chances. And again, let's make sure the person is getting the help. And you don't have to make these decisions yourself. You have in your community cutting edge mental health professionals. I was with them Thursday night. You have very good people. The schools are well provided with. I think that you can turn to the other people and don't have to be ashamed. You can turn to those people to please make the necessary assessments and try to determine it as best as we can. Sometimes a similar kind of issue will come up. Teenagers sometimes like to be funny and outlandish, and sometimes they'll say sort of a joke, well, I'm going to kill myself. I don't I take that seriously. You know, they didn't do well on a test, or the potential boyfriend, girlfriend doesn't want to go out with them or something like that. Oh, I'm going to, you know, that's not a joke. There are people that really are suicidal. So if you are, we have to do something about it. And if you're not, you don't talk this way. You don't make jokes about cancer. You don't make jokes about heart attacks. You don't make jokes about suicide. It's real. So we have to sometimes, as I said, sometimes people will, and we have to learn not to do that. We shouldn't make jocular remarks about taking one's life. I once went to one of my grandchildren's, I don't remember if it was Siddur Chumash play, it's all a blur now, but the Rebbe, who was a very good Rebbe, wanted to tell his children a story that was entertaining, and told sort of a funny story about someone who went out and killed themselves. And I went to him after that, I don't know if he got it. I said, you can't tell that story. There's a dramatic increase in teens and even preteen children suicide. Now, again, it's far from a majority, but it's not something that it should be discussed in a jocular kind of way. I think my Ritalin must be wearing off because I'm going off on tangents, but I apologize.
We're appreciating your tangents just as much as your answers. Thank you very much.
Okay.
There's a chat question or comment that I think it bears addressing, which is this individual doesn't want to contradict my wife, who had to step out, but he says that there's a misplaced ego in our community about us being warm and welcoming. It's very selective. I wouldn't use the word selective. I would agree as a rabbi from my perch, so to speak, from my vantage point. I know that there are major gaps, meaning that that in general, we have a loving community, and there are people who end up being ignored or somehow shunted aside, or people don't realize, or whatever it is, but there's no question about it. I hear a tremendous amount of appreciation for the warmth of our community, and then I have often enough descriptions of people feeling totally isolated and ignored and not tended to at all. So let's recognize that we're not perfect, and we can always do better. And I can do better. I can tell you that I have often ignored people not on purpose, but ignore them nevertheless. It's just we're human beings. But there's no question that we can do better. I mean, that's one of the heightened awarenesses we want to have here. Enough said.
Mm-hmm.
So I just want to, I mentioned before we were zooming in, I'm going to zoom out for a second. A lot of questions are coming in about the following. And I also want to apologize in advance to those in the chat. If I don't get to your question, it's not personal. Just trying to keep organized as best we can, and we'll do the best we can. A question that came up in a number of different ways is how do we not? I wouldn't say deal with this. How do we grow as a community? What are some specific or concrete actions that you would suggest we take on a communal level? As a result of the recognition of the importance of mental health. And how do we set up systems that can help people going forward?
Okay. Well, I think they've been addressed both by Harvey Feldman and I believe subsequently by myself. But something, stigmas are very, and especially this one, are very ingrained. Are very, for generations and generations. We looked at mental illness and originally as somebody being possessed by some dybbuk or something like that. And later on, unfortunately, caused by poor parenting. Sigmund Freud made a very huge contribution to humanity, but one of the problems was that he did disproportionately place blame for mental illness. I mean, he didn't know. I mean, I don't know if he meant it to be mean, but he disproportionately placed blame on parents. And I can tell you that I've seen parents who are just absolutely wonderful, wholesome, coordinated, who have a child with a serious mental illness. And I've seen some parents who are just seem to be doing everything wrong, and the kid is like robust and healthy. So there's a lot more, especially today, in our day and age of internet and technology, a lot more impacting on our children than parents. So we have to be very careful not to be parent blamers. And even if we see a child who's struggling, the struggling can be mental illness, the struggling can be what we used to call off the derech, children who are leaving the religion, and we're very quick to look for culprits and blame parents and blame schools. And And that's a gross oversimplification. So we have to be warm and sympathetic and caring. Again, use your Nebuch, the child has cancer mindset. If somebody's child has a mental illness, and you know, I will tell parents whose children, let's say even who have children who have made suicide attempts, etc. I will constantly tell them what wonderful parents they are, and they are. I'm not lying, not just patronizing. They're great parents. There's just, as I said, there's genetics, there's outside factors, there's so much that goes into what caused them. So that's probably priority number one. And that's, by the way, what we do in schools. If there's a suicide in a school, either of a parent or of a classmate, we sometimes we have to address the whole issue of suicide, and we do that, but our subsequent programming is not on suicide. Our subsequent programming is on mental health, mental illness, psychotherapy, medication, to work on destigmatizing that. That's probably priority number one, certainly what was alluded to in terms of embracing and accepting. And I will tell you something else, piggybacking on what Rabbi Feldman mentioned. Shuls very often are places with people who have, unless you're forgetting some of the more severe mental illness, like if you're getting to, let's say, schizophrenia, bipolar, people like coming to shul, because for many of these people, interpersonal relationships are very dangerous. People take advantage of them, people hurt them, and shuls are safe places. And sometimes people with some pretty severe mental illness wander into shul. Every shul has them, you know, and I know we do in my shul. It's a large shul in the 5 towns. And we need a protocol and a method to include them and to work with the providers and the family and et cetera to embrace them. OHIL, for example, has about 80 homes for people with psychiatric illness, with cognitive challenges, with autism, and they're all situated near shuls. And we work with the shul to have, you know, that these people should be invited for meals, can walk into shul, and the shuls have been great, have really been amazing. But that has to be, again, part of, it's not just anybody who comes into shul, but sometimes people with emotional vulnerabilities, just as the Rebbitzin alluded to, feel safe in a shul setting, rightfully so, because we're good people. We're not going to harm them. And I think we also have to be aware, you know, another topic that I didn't get into, we have to know, especially if we're dealing with our children, but even with ourselves, what are they watching? Who are they communicating with? For example, there is such a thing as brooding I mean, there's so much to talk about, but with social media, people who are depressed find each other, especially teens, and they will, there is a kind of reinforcing the morosity and the pessimism. And while it's a very delicate balance, but we don't want to intrude in our children's, especially teens' social life. But if we have a suspicion that something of that sort is happening, or that they are on certain sites that may promote, and there are ones that promote either violence or self-inflicted injury. I mean, many of the kids, when we get called in for postvention, even as young as 10, when after they've taken their lives, it becomes apparent that they were on a site that told them how to do it. So we need to be, again, without being overly intrusive, with knowing our children, knowing which children are vulnerable, which aren't, but we have to have an awareness of what they're watching and who they're interacting with online. These are all just like, you know, if I was a cardiologist talking about heart disease, I would be talking about exercise and you know, and nutrition, along with, you know, getting your echocardiogram, et cetera. And so there's much we need to do as we promote physical health, also to promote emotional health as well. And that should be one of the takeaways, I believe, from a tragedy that happened here.
Okay, thank you. There are a few questions surrounding the point of finances. There are people asking that sometimes the staggering cost of psychotherapy can actually just, you know, add to the difficulty of the situation. Somebody else added that some of the New York programs that have been mentioned are not available to those who live outside New York. So what can we do about finding resources?
Yeah, that's a tough, you know, I always tell my patients, I couldn't afford myself, you know, it's, you know, how they do it. So this is a big problem. It is a big problem, and I do hear about it more. Yes, I will say, fortunately, in New York, we do have several FIFA, FIFA's not FIFA serve. I mean, sliding scale facilities that are manned completely by Orthodox, or predominantly by Orthodox Jewish clinicians. So there is that option, and there are charitable, organizations that do help subsidize therapy. And that may not be available in smaller, more out-of-town communities. But again, to the extent that you can, that should be. I mean, Jewish Family Services. I'm not familiar personally with Atlanta, but I know of Jewish Family Service branches in other cities, and they're all very good and really provide excellent service. And by the way, there is some data to suggest that, because many of us are manned by novice therapists, that novice therapists have almost close to the same success rate as more senior therapists. And the belief is that because they devote so much of themselves to the care, they put so much into it. Because I mean, I still remember my first few cases, and I didn't know what I was doing, but I was so invested that I think we compensate. The field itself is attempting to streamline therapy as much as possible, to find methods that work quicker. I personally am finding myself working much more on, let's say, on an every other week basis, maybe with homework and things like that, to try to defray the cost. Their group therapy, by the way, is, many people look at group therapy as sort of like an inferior or a backseat kind of therapy if you can't do individual therapy. But the outcome studies on group therapy are not only comparable to individual therapy, but in some studies even outpace individual therapy. And group therapy is, for obvious reasons, less expensive. And then sometimes, and I hope I'm not going to look like I'm saying this for self-serving purposes, but sometimes I've had patients tell me they've made money on therapy because of their better functioning. They're functioning better on their job, and they're more successful. And sometimes we have to sort of dig deep into the pockets, or turn to people who can help us and ask for assistance for psychotherapy. You certainly have a right to get a sense from the therapist how much time is involved. It shouldn't be interminable, and whether progress is being made. Even, by the way, if it's a teenager and we're not necessarily sharing what we talk about, I tell the teens that I work with that your parents are paying for service. They right to know if we're getting somewhere. So I will certainly share with them what I think in terms of if we're having some success or not. So again, with those caveats, but it's sometimes money well spent.
Okay, thank you. I'm going to ask a question. I'm going to pull a question here from the chat, which is
sure,
just a different type of a question. Somebody asked here. I hope it doesn't take us off topic, but it's all on topic. And I also just want to note, if I didn't get to any questions posted in the chat, any of the direct messages, please feel free to text me later. They're all important. They all need attention and discussion. So text myself.
Also, Rabbi Foxbrenner has my contact information. If somebody wants to talk to me some more about something, I think it's just easy just to please ask Rabbi Foxbrenner to share my contact information.
Sure. Okay, I will do. So feel free. Don't feel like you're bothering me or taking up my time. I'm happy to hear from you.
Right.
So the question here is, I'm just going to read it. I learned a person can be happy and sad at the same time. How do we get to the happy part, especially since it's Hanukkah?
Okay, so eat a lot of latkes. No, how do you get to the happy side? So I think, first of all, we have to define what happiness is. Okay, and that could be a whole discussion unto itself. But I'll reference maybe one of the most famous studies on happiness, which was done, it's hard for me to imagine, but it was done about 25 years ago. It was published in the American Psychologist, which is the journal of the American Psychological Association, in which they did a huge international study on happiness. Want to know what makes people happy. They couldn't call it happiness because that doesn't sound scientific, so they called it SWB, subjective well-being, but it's happiness. And they came up, and this was a very large study, so it was They came up with the 3 Fs, 3 things that start with F. Now, if it was a smaller group, we could have some fun trying to figure out what the 3 Fs are, but I'll share it with you. The 3 things they found were family, friends, and faith. Now, you might ask, how do you measure faith? You can't measure what somebody's heart. So they measured faith by membership in a house of worship. So if you're a member of a synagogue, a church, a mosque, then that would be considered faith. So as we used to say when I was in yeshiva, what's the tzara shava b'neihem? What is the common denominator? Family, friends, and communal connection. And it's people. And what makes someone happy is people. It's not roller coasters. It's not wealth, money. There was no connection. It's not a delicious meal in an exorbitant restaurant. What makes people happy is to be connected. So if you want to, and no accident that our holidays like Hanukkah are so people-oriented, get-togethers, Hanukkah parties, gathering. I mean, unfortunately, now we're limited because of COVID, but it is so centered around being around other people. So my best answer to that question is we make people happy by connecting to them. We make people happy, as the Rav mentioned, by calling them and just saying, how you doing? You know, I remember during a very difficult period when I was going through a very hard time, I have a very difficult period in my life. I'm very close with a certain Rav in the New York metropolitan area. And out of no place, a postcard came. And said, you know, he said to me, Chos Chen Chen La was in this past week's Haftarah, wishing you great happiness and charm, whatever. Signed it by his first name, and this is a rabbi who doesn't necessarily go by his first name. And I can't tell you what that postcard did to me. And I have it, by the way, where did I must have just fallen down. I have it framed on my desk, and because it's a small little, it gets knocked down, so it's probably knocked down, but I have it framed on my desk to remind me. So to answer your, best way to answer your questions, yeah, send somebody a postcard, send them an email, give them a call, invite them over, and not in a pitying kind of way, but with dignity and respect, check in on them. And I think that's what makes people happy. Okay. And by the way, it's also an antidote I mentioned earlier to suicide. It is an antidote. Yeah, okay, I'm sorry.
So on that note, I'm gonna frame your face here and
okay.
Thank you for checking in with us, for sharing with us your guidance, answering our questions. Do you have anything that you'd like to add before we sign out tonight?
Well, I just, you know, I think one more point is also, and maybe that speaks to the, you know, to some of the, and not stigmatizing mental illness, is we have to stop being afraid of our humanity. We're not all, you know, invincible. I think one of the terrible disservice maybe that the hero worship of quote unquote Gedolim has done is that we've made them into superhuman people. And we hear stories about great people who went through the Holocaust and was never cried and was never sad and suffered terribly and were, you know, were never, you know, still had this faith in God and remained happy, which they may have, you know, there may be great people like that. We're human beings. And in fact, we don't have to go further than the Parshas we're reading in Bereshis. Now, the Avos and the Mahos had all the emotions in the world. They were sad, they were scared, and what they did with those emotions made them great, made them different than us. But I think part of destigmatizing mental illness, and for ourselves and for others, is to realize that God didn't make us angels. He didn't make us superhuman beings. He made us people with vulnerabilities and fears and pain, capacity for pain. And we don't have to hide it. We can share it and work on it and help each other. And the world will be a better place if we do that.
Okay, Dr. Blumenthal, thank you very much once again.
Thank you.
Thank you for joining us. And I hope we'll have it
anytime. And please feel free to contact me again. It's easier, I think, do it through Rabbi Foxbrenner, if you don't mind. But if anybody needs to talk about something further, please feel free to contact me.
Okay. Thank you very much.
Okay, thank you. Thank you. You too.
Serious Thomas.
Amen.